Hey, this is Pat Iyer with Michelle Gaines, who is a nurse anesthesiologist. We have a great treat for you today to talk about polypharmacy, and it may not be what you're thinking of. Michelle's responsibility in analyzing cases as a legal nurse consultant and expert witness is piecing together how the drugs interact and how they impacted a case. Michelle, many of us who are not involved in the field of anesthesia may look at the record and look at all those medications and look them up and trying to figure out why, what happened, what was given, what occurred. Give us a sense of how you look at the medications that are given in the course of anesthesia.
Thank you, Pat. It's good to be with you this afternoon and have this conversation. So when I look at an anesthesia record and I'm thinking about how the medication is being delivered, one thing that I think some people that aren't in anesthesia don't realize is the medication record may show, let's say, for instance, propofol and a dose written down. And you know that we give it IV push, but that doesn't mean that every drug that we give, we slam in IV push. A lot of times we will titrate to effect and then we just write a number down. That's the dose we gave. And that drug could have been given quickly if it's an 18-year-old getting the drug, or it could have been given over a few minutes if it was an 86-year-old getting the same dose. And that will not necessarily be reflected in the charting. The other thing that I have seen is we do mix some medications. We use one medication purely to counteract the side effects of another medication. And for someone that's not well versed in the anesthesia world, they may think that, oh, you gave a drug and now you're resuscitating that drug with another drug or covering up the side effects, when in reality, we have planned that all along. So anesthesia is very dynamic and can be somewhat confusing if you're not looking at anesthesia records all the time.
What are some typical drugs that are given to reverse anesthesia?
When we put someone to sleep, especially if they're going to have a procedure that requires their muscles to be relaxed, we give a drug called a non-depolarizing muscle relaxant, not like a muscle relaxant you have when you have a back spasm. This is a muscle relaxant that actually paralyzes the muscles so that they're loose, so the surgeon can work more easily. And even though we have a monitor that gives us an estimation of return to function of those muscles, there's plenty of literature in our literature that says the patient would still have a degree of that medication in, and we should reverse that medication. And it's a competitive reversal. So we'll figure a dose. Well, the medicine that we use is called neostigmine. And if you just gave neostigmine to someone, you would cause a bradycardia. So we have to give a drug like Robenol or atropine. And we usually give the neostigmine with the Robenol, say, in the same syringe. But the Robenol actually works about 3 minutes before the neostigmine works. So we get a tampering down. We actually, a lot of times, will see a tachycardia because of the Robenol or atropine. And then the neostigmine hits and the muscle fibers come back stronger on the little monitor that we're using. So it's all about timing. And I tell students that come through, we look like ducks floating on a pond, when in reality, we're swimming underneath, doing multiple things at once.
You know, I know that there's a fear in some people that they're going to wake up, that reversal process has taken place, and they're going to feel something because the surgery isn't quite over. Tell us about that timing Is that indeed a valid concern?
Let's see. So there are incidents of awareness under anesthesia. Thank God it's a very low number. It tends to happen in trauma, in severe cardiac surgery type situations. Sometimes it can happen in OB, a stat C-section, where we're rushing to get a baby out to save a baby. The mother may have some recall because our medicines aren't working as fast as the surgeon's working. In trauma, it can happen because the patient basically comes in dying or dead, near dead, and the trauma team starts, and as the trauma team is working, the patient's getting better to a point that then there's good blood flow to the brain and there's some awareness. We do have some monitors now that we can use for, it's called a BIS, bispectral index. They put a sticky pad on your forehead and the technology can tell if there's awareness. So that's one thing that can help. Not everybody has access to those. They're not a required monitor. But I wouldn't poo-poo what somebody is afraid of, that they could wake up and their body still be paralyzed, but it is extremely rare.
Mm-hmm. You mentioned the reversal agents, and I know that there's a lot of controversy, particularly right now, on off-label use of medications that are intended for humans, and then there's the whole off-label use of a medication that's intended for horses and cattle that people are taking in an attempt to prevent or treat their COVID symptoms. And we can get to that topic in a minute, but in the anesthesia world, are all medications that you use in the OR approved by the FDA for that purpose?
I will flat out say no. And we could go down a rabbit hole on FDA approval. I wrote out a little history, and I'm not even going to probably talk about the history of that. But I'll give an example of a drug to explain how medicine advances by using things in different situations. And you can't study everything to the degree that the FDA studies things. If we took all the medicines away that were not FDA approved, people would suffer, and we would have very few medicines to use. There's just not enough money and time to study everything to the nth degree, like an FDA approval will give you. For instance, there's a drug called Precedex out now that came from the ICU world, and it was developed to keep people who were on ventilators, that you wanted to wake them up and assess them and then put them back to being heavily sedated without hindering their vital signs, and it being a pleasant experience. And they came across this drug and it worked quite well. And of course, we have anesthesiologists who work in critical care areas, who oversee ICUs. So I'm sure there was a bright anesthesiologist somewhere that said, I could use that in the operating room. And so Precedex made its way into the operating room. And this is what you will probably find, your readers might find unsettling if you think everything is FDA approved that's used in the medicine, is it's particularly made its way to the treatment of children. In that, when you ask an anesthesia person, if you had the ability to wake up someone smoothly, what patient population do you need that in? You need it in kids. Kids in the past could wake up screaming, unconsolable. That's what you don't see behind the closed doors, is they're not with their mom and dad. They haven't had breakfast. What have you done to me? And so we would give narcotic. You need a certain degree of narcotic, probably if you had surgery, but maybe you had a short ear tube placement. You don't even have an IV. those kids, we would give oral medication to. But let's say you had your tonsils done and you did have an IV. Well, we don't want to give a tremendous amount of narcotic because we want you to get up and get going and have your popsicle and go home. But you might wake up and be inconsolable and flail about and maybe hurt yourself or pull out your IV, and it's just a mess. So someone decided to come up with a small dose of Precedex. You give it to the child. They wake up very smoothly. They have their popsicle and they go home. And the world of child anesthesia has just been changed by this drug. And it's not FDA approved in children.
Mm-hmm. That's a great example. I wonder if it's ever injured anyone.
I think if you gave some tremendous dose, it comes in a small vial, our pharmacy pre-mixes it up into appropriate dose syringes so that it would be almost impossible to hurt someone with it. But I think if you were out somewhere that you didn't have pharmacy backup and you just picked up that vial and you didn't know what you were doing with that drug and you just drew it up and gave it, yeah, I think you could cause a problem. It not being correctly diluted to the correct strength for the correct patient. So
Right.
I think with any medication, there's always a risk of having a problem.
In our hypothetical case that we're talking about, and this is not based on any real facts, I could see an attorney and a legal nurse consultant saying, you gave a drug that wasn't approved by the FDA for that purpose. You didn't give it properly. You injured the patient. I got a good case.
Well, maybe we should go back and talk about the history of the FDA. And I can tell you it was created in 1906 in response to a novel that was popular at that time. And it was called the Pure Food and Drug Act. It prohibited the manufacture and interstate shipment of adulterated and misbranded food and drugs. And then in 1937, we had over 100 people dying after ingesting a magic elixir that contained diethylene glycol, or you know what that is?
I would like to say yes, but
It's the antifreeze.
Okay.
I always think green, yellow when I hear that name, the antifreeze. So we had people dying from ingesting an elixir that contained antifreeze. That prompted the Federal Food and Drug Cosmetic Act of 1938, which you had to demonstrate safety before manufacturing new drugs. And then in 1960, Pat, you're old enough to remember thalidomide. Thalidomide did not get approval in the United States, but it was used around the world. And so our country was one of the countries that did not have the birth of children with arms that weren't developed well. And because of that, in 1962, they passed the drug amendment, the first drug amendment to require demonstration of effectiveness before marketing. And since 1962, there's been more than 1,000 prescription drugs that have had their labeling changed or been taken off the market altogether. And so generally, new indications for a drug require evidence of effectiveness based on data submitted from adequate and well-controlled studies. And here we get into where we are today, is people wanting FDA approval. There needs to be conducted studies, but we also know for the scientific method to be true, those studies have to be replicable. You have to get the same results repeatedly, and it takes time. And therein lies the rub of cost money. It takes time. Not that long ago, we wouldn't have hardly anything FDA approved for children, pregnant women, breastfeeding women, because the study population tended to be 35-year-old males. It's only recently that is starting to be addressed. There's no reason to go back. It's hard to get financial. I'll take an anesthesia drug, fentanyl, which has been around since the 1960s. We use it like water. We use it intrathecally, which means in spinal blocks. Patients don't get nauseated. They have good pain control. But that's not FDA approved for intrathecal use. But that drug's been on the market so long, no one's going to pick it up and take it back through the process. It costs too much money. System's not built that way. So I would argue that off-label use plays a vital role in practice in the evolution of medicine.
And before we leave the topic of fentanyl, I know that I have seen news reports of people who have overdosed with heroin that was mixed with fentanyl. Can you give our listener a sense of why that combination is so lethal?
Well, street drugs is not my forte, but I have heard through the grapevine that almost every street drug out there is currently being mixed with fentanyl. And I know that fentanyl comes in different types as far as how it appears and different strengths. But I can tell you what you're getting in the anesthesia world is actually a well-controlled, we know exactly how much we're giving, we're knowing exactly when we're giving it. And I think on the street, you don't know what you're getting. You don't know the purity. You don't, and heroin is a narcotic. Fentanyl is a very, very potent narcotic. And what you're getting is you're flirting with death by doing that.
Mm-hmm. And speaking of flirting with death, I have heard of cases where anesthesiologists have been found with needles in their arms. They've been found dead. Can you give our listener a sense of why substance abuse is so high in the anesthesia world?
Well, Pat, I hate to tell you that you and I could talk for probably the rest of the afternoon about anesthesia abuse by anesthesia providers. If you're in this business long enough, you've either seen it or heard the stories. And I think it all boils down to access. We have access to a lot of medications. And even though you have to check them out and you have to sign them and you have to do all these different things, if you want to, I can't even think of the word, take the medication and replace it with something else, you have plenty of opportunity to do it. And if you have discovered that you like the way you feel on a particular drug, you have plenty access to it.
So even though there are controls in place, there are ways around that.
Human beings are very smart.
Mm-hmm.
And if there is a system, we're going to figure out how to get around it. And I think anyone that wants something bad enough can figure out a way to get around a system. What you've indicated, though, is what happens in the end. If someone gets involved in that type of thing, then eventually it takes over their life. I know that the American Association of Nurse Anesthesiologists has a big program to help peers that are under the influence or trying to get out from under the influence or trying to get back in practice after going through rehab. Very supportive, big program. But, it's available. That's why we do it. I've heard the saying, the alcoholics are at the bar, well, the narcotic users are in the OR.
Mm-hmm. And in nursing, when a staff nurse, say on a med-surg unit, develops a substance abuse problem, there's the potential for putting them into another area of nursing where they're not handling medications. Is there such a potential for nurse anesthesiologists who develop a substance abuse problem?
I will say that the boards of nursing are probably harder on nurses and advanced practice nurses than the medical board is on anesthesiologists. But that being said, I just recently was involved with a presentation by a gentleman through the American Association of Nurse Anesthesiologists who had walked the walk and done the talk. And he had became a narcotics abuser as a nurse anesthetist. He had lost the ability to practice. He had gone through rehab. He then went through the program to re-enter. And he said it is a long, hard road, but he is doing it. So there is a method to get back into the anesthesia world. I know every form I've ever had to fill out to be credentialed, you have to talk about that, whether you've been involved in rehab programs or lost your license at any point. So I think you can get back into anesthesia. I think it's incredibly hard.
Mm-hmm. From the medical malpractice standpoint and intersecting this with legal nurse consultants, I could see and envision a case involving a provider who was under the influence, delivering anesthesia, not attending to the clinical signs of the patient. And then in the process of investigating this case, all of this comes to light.
Mm-hmm. Mm-hmm. Yes, I think we're taught in school, obviously, to be aware that abuse is an issue. If you have patients waking up in pain a lot, one provider in the recovery room, people need to be suspicious. Is somebody taking narcotic and replacing it with normal saline, or is something going wrong that it's not accounted for?
Mm-hmm. I worked on a case involving an infectious disease doctor who had a substance abuse problem and turned himself in when his supplier was arrested. And this gentleman was involved in a case of a patient who had an anaphylactic reaction to a cephalosporin. And the question was the doctor impaired at the time that he prescribed the cephalosporin? It turned out that one of my clients was ready to hire this infectious disease doctor as an expert witness. And I knew about this man's history because I was defending the two nurses who were at the bedside when this man had the anaphylactic reaction. And I faced that ethical question of whether I should tell client A about what I had worked on with client B to protect him from hiring this doctor. It turned out the defense firm in both the potential case of the doctor acting as an expert and the actual case where he was a defendant, it was the same defense firm. So my client was profoundly grateful when I said, you may not want to hire this guy as your expert. He's got a little skeleton in his closet. I first checked with the client whose case I was working on when I found out about this doctor. And I said, am I violating any confidentiality by sharing what I know about this doctor? She said, no, it was in the newspapers. He was arrested. He went through drug rehab and ultimately was able to go back and practice. So my client was sitting in his driveway about ready to drive over to talk to the infectious disease doctor to hire him when he opened up my letter and read about this doctor and went, holy cow, I do not want to hire this man as my expert. And surely this would have gone very badly for me if I had done that. The potential, and that's a twisted story, but the potential for injury to a patient because of the judgment issues, the lack of attention It seems to me that would be very high in the anesthesia world. Of course, it could be very high in other aspects of medicine. And I wondered if you are aware of situations where an anesthesiologist or nurse anesthesiologist or anesthesia assistant might have been caught up in that type of scenario.
Well, I know of people, yes. I've never been clinically in a situation that day, right then, that I suspected something was going on by either taking over care or being involved in care jointly. But for the 27 years I practiced anesthesia, I'm sure somebody has snuck under my radar. I'm sure it has happened. And I just haven't. But of course, I do have stories about the person found in the lounge, found at home, found in different places out because of narcotic. And I'm afraid I do know of one peer that passed away. But so I know it's out there. But no, I think people are pretty slick most of the time, and you don't realize that it's going on until they're caught or they overdose.
And it may be more obvious with alcohol consumption. I've heard stories of doctors in particular who came into the hospital having consumed too much alcohol and then got caught. Somebody smelled something, somebody observed their behavior, they were escorted out. Perhaps if you are high on something, it's not quite as obvious. You're not going to smell anything.
Oh, you just said something there that opens up a whole can of worms, and that is the use of cannabis. And where is it legal and where is it not legal? And what does your board of medicine or board of nursing think about that?
Can you elaborate on that?
Well, not particularly, but what?
Oh, firsthand experience, I know.
But what? No, not from firsthand experience, but from seeing it in my patients. I live in Austin, Texas. That's a pretty liberal town. It's a college town. Used to be, you had to drag it out of people if they used marijuana or other medications. And they might not tell you till you get behind the swinging doors and they get away from their family. And then they'd be, okay, I do this. And you're like, okay, I just need to know. And now it's very common, even though it's not legal in this state, in this city, but the city turns an eye and it's out there and people will say, yeah, I do it weekly. Yeah, I just moved here from Colorado. I go back to the dispensary and bring it back home.
Mm-hmm.
And that goes into our anesthesia practice. And we're now having more and more CEU classes on dealing with patients that chronically use marijuana. And it's not without problem. People think, oh, it's completely safe. There again, it's a substance, like an FDA regulated substance, but it's not really regulated. And it does cause changes in your physiology.
Mm-hmm. You put me back in a line in the airport in Las Vegas when I was out there a few years ago, and there was a drug sniffing dog and a policeman who was checking out all the passengers in Las Vegas to determine if they had any drugs in their carry-on. And it was all done with hand signals. I watched the whole process. I was fascinated by it because the guy who was in charge of this dog was running with the dog, and he came to each person and he did this with his finger to get the dog's attention, and then he pointed at the bag, and the dog walked over, ran over, sniffed it, and then they went right down the line, checking out everybody's bag. And at first, I was bewildered by it until the brain synapses went together, and I thought, okay, that's what they're doing. Now, they didn't catch anybody during the time that I was in line, and I assumed that the people who bought drugs in Nevada consumed them in Nevada and didn't take the risk of putting them on the plane and going to another state where it wouldn't be legal. But that dog's job was to catch that.
Mm-hmm.
And in states where it is perfectly legal, yes, then that would have implications for, was that person taking cannabis prior to going under anesthesia? How would that affect your care, your outcome, the patient's outcome? What do you do differently if you know that that person smoked for a little bit of courage prior to getting in the car to drive to the hospital or
Right.
surgery center?
Well,
Yeah.
first we would say don't smoke anything the day of surgery. It irritates your lungs.
Right. Exactly. Exactly. That could be a good way around it. Well, I know that this conversation may stimulate some people who've got questions about anesthesia medications, the impact of anesthesia medications. You provide expert witness services to help evaluate the standard of care delivered by the nurse anesthesiologist in a case. How can our listener find out how to connect with you?
You can find me on LinkedIn, Pat. I also have my email, Michelle with 2 L's at mmgaines.com. My last name is Gaines.
All right, Michelle Gaines, expert witness for nurse anesthetist, nurse anesthesiology cases, knowledgeable about all aspects of giving anesthesia. And we've covered a lot today. I know that you still may have questions after listening to Michelle's presentation and our conversation, so be sure to connect with her for assistance on a case involving the issues of her area of expertise. And tell another legal nurse consultant about Legal Nurse Podcast. We are now in our 6th year of production. I find nurses who have not heard of our show, even now after 6 years. So spread the word and let others know about the value that they can obtain by listening to Legal Nurse Podcast. Thanks so much. This is Pat Iyer with Legal Nurse Podcast. I have just been speaking with Steve Kachik about difficult people and awkward conversations and how they can influence you as a legal nurse consultant in interacting with your attorney clients. Steve, what were some of the highlights of what we just covered in your podcast?
Well, Pat, the highlights are really covered by an acronym I use. And I say difficult people, awkward conversations. They could be angry people or just people who just never always want to work things their way. So I use the acronym, I now use the acronym BREAD, but it starts with READ really, because the first thing is about building rapport, finding your common interests as soon as possible so that you can relate with them and connect and be in harmony. The E is for empathy. And the empathy is to make sure that you actually imagine what it would be like if you were in their shoes, how you would be responding. And from that position, you're now responding. You're listening empathically and responding empathically. And being aware that there are triggers like I understand and but or however. But and however negate what you just said. But I understand will tend to make people never understand exactly what emotion they're going through. So saying things like I appreciate, I respect, I recognize, or I can only imagine, things like that is a way of keeping the empathic phrases. The A is for assertiveness as opposed to aggressiveness and passiveness. And when you're assertive, you are not getting drawn into emotions and reactions. You are staying solution focused, win-win, as opposed to my way or the highway with the aggressor. And finally, the D is to stay detached. That is, don't be attached to the outcome. Stay not attached. So you're only looking for what outcome is the best outcome, not your solution. And if I go back to the beginning with B, think about your behaviours, because your behaviours can aggravate the situation.
That's just a taste of Steve Kachik and what he covers in his podcast. Be sure to catch his podcast on this topic and take heart, because there are some techniques that he shares that helps us to diffuse those difficult situations and give you a sense of control in a situation where you might feel out of control. Be sure to get Steve Catchett's podcast, and I'm Pat Iyer with Legal Nurse Podcast.